come tell us.
All right. So we talked about access, who's teaching, who's receiving educational opportunities. Well, we said it's quite common for those from the global north always teaching the global south. Historically, medical missionaries were part of the ones doing the care, people trying to establish training programs. And we started talking about what exactly would we need to make that happen. We mentioned sustained funding to make that work at an institutional level. Again, this is still kind of thinking about global north going to the south. But assuming we want some sustainable funding, sometimes that is more likely to come from high-income countries, but ultimately the goal would be to have a partnership, whether it's the Ministry of Health, we drew upon experiences of some of our other group members here, to have some bidirectional funding. That way both parties were able to be accountable, ensuring that we're planning at a high level for sustainability from the outset. And when it came to creating a memorandum of understanding between people doing medical students, rotations, that was kind of the example that we took away. What sort of things do we want before we establish that partnership? The big thing we talked about was a stakeholder analysis and setting expectations at the outset and ensuring that there were logistics and funding in place to ensure that this was bidirectional from the outset.
Thanks so much. Group 2?
I'm going to break this again.
All right. So our topic kind of incorporated a lot of the other ones to a lesser degree. Sure. One of the first topics that we touched on was the use of culturally insensitive idioms, such as powwow, and just being aware of those as we start to communicate with more of our global colleagues, because we could easily offend someone without realizing it. Then the more obvious thought was a crash course for the country or region you are traveling to, just to get more cultural awareness and maybe even some language skills on where you're going, so that you're not as much of a burden and that you're able to kind of take away more. And then we discussed aspects on how to accomplish this goal, since asking someone from that culture would be placing a double burden on them, as they would be teaching you before and during their stay at the hosting country. So one of the proposals to help address this was that the learner must take it upon themselves to create a presentation about the culture they're traveling to, and have this presentation kind of verified or checked by a local. Let's see, I can't read my handwriting on this one. Oh, reframing these experiences as learning opportunities, making it clear that you are not going necessarily to help, that you are likely going to be a burden, and that this should be looked at as another class that you've signed up for with learning objectives. And then there was a more longitudinal aspect to this. Instead of having this just be a one-off with a course, you are paired with someone of equal training, and you have a longitudinal relationship over the course of several months with possible reciprocal exchange. So one participant travels, and then maybe 6 months later, the pen pal, so to speak, comes and visits your home institution. From a licensing perspective, we recognize this will be difficult, and it'll likely work best with medical students.
Thank you so much. Group 3.
All right, so group 3, we talked about the language we use in global health. We want to make sure we're getting input from low and middle income countries about how they prefer to be described and addressed, see what they determine to be respectful, appropriate language to refer to their countries. And then also using language like, we talked about using the language of helping versus learning, that we're not going to, being really mindful of what that implies if we're talking about going to help versus going to learn or partner with or work alongside. We talked about the language around resources, resource-limited settings versus resource-denied settings, I believe was spoken about in the introduction. And then also consider what resources are we referring to? Are we referring to limitations in financial resources, human resources, physical resources? Also, be mindful of who is assigning the roles and titles that we use in our publications. Often those are assigned by people in power versus the people that are labeled with those titles. Be very mindful in the language we use to not portray the savior complex. And then also the actual language. Are we using English? Are we using preferred language of the people that we are speaking to and publishing about? We want more equity in publication language, more access to interpretation, both for our partners, for our publications. We talked a little bit about, if we're going and expecting someone to interpret for us in the country we are researching in or teaching in or partnering with, we want to be very reciprocal with that, inviting those colleagues to come and providing language support for them. Our action items, we want to call all of our colleagues within the academic global health realm to action to assess the language that they're using at their institutions and any publications they put forth on their websites, how they market and advertise the programs that they put forth. And then we want to have a consideration to publish in the first language of the country in which research is performed. If that's not the primary language, at least have interpretation in that language available. We want to be mindful of authorship for any publication that's put forth, talking with colleagues in our partner countries about their preferences for authorship. We can't necessarily assume that being a first author is the most prestigious order in their minds, and so talking with them about how to meet their needs, how to collaborate with them on how we list people, how we describe their roles. And then we want to encourage building in language learning time for students, residents, faculty that will be having international experiences. Whenever feasible, at least having basic introductory language or having available language support for them to learn at least the basics of the language of the people they'll be interacting with.
Thanks so much.
You're welcome.
Group 4.
Okay, so we talked about a lot of things that people had already sort of discussed, so I won't touch or rehash them too much, but we did representation. So our low-income countries, how are they portrayed in our educational projects, and how can learners document their projects equitably? So we did talk about the exchange of learners and the helping versus learning model, and then we also talked a little bit about the promotion stuff, so I'll jump into that. So we said that the low and middle income countries aren't really represented equitably in our academic and research projects. And so one of our actual items would be to change our promotion structure. So reaching out to other departments, specialties, and demanding first author representation and requirements for promotion. And it was brought up in our group that when you include other departments, not just emergency medicine, but surgery and OB-GYN and other people, you have powerful allies within the hospital, and if you all demand the same things, this might be a way to push your agenda forward. We also talked about co-first authorship, getting journals to accept this as the new norm, as well as somebody brought it, like, make Harvard do it, and then everybody else will fall in line.
Not necessarily true.
I know, we were just kidding. And then also building into the promotional structure educator roles and lines. So if you are an educator, that can be a part of your promotion, not just always first authorship, and a weird point structure based on that. And then from the learner perspective, so to invite experts from low middle income countries to teach via Zoom. Basically, we need to call them as they are. They are experts. They're experts in resource-limited situations. They are experts in their fields. They're experts in tuberculosis and all the like extrapulmonary findings of TB. Like, we shouldn't necessarily in our like high-income places be teaching that when we see 2 cases a year. We should be inviting the people who are seeing this on the daily. And so options of like pre-recording and then doing like a question-answer session because sometimes the internet doesn't work, and doing other like, yeah, I think that's about where we go. We're good.
Last group, recognition.
Right, yes, oh yeah, we fly in grand round speakers all the time. Why are we not taking the experts in the fields and bringing them to us? Do it constantly.
And paying them. Great, thank you.
And, right, and paying them.
Quickly, recognition.
Yeah, group 5,
Also
they
ask,
will kick us out, but we want
please scan the QR code, add your information so that you can be included as a contributor on the committee.
Also, please, everybody put your chairs back in nice rows.
Yeah.
Because as the guy who's moderating the next session, I want to get something with that.
Thank you. Sorry.
No, not at all. I want everybody to do their part first, so we'll help that.
Hello, team. Sorry, I know time is running short. So I am David, representing Recognition. Main issues here primarily in terms of recognition, in terms of expertise or promotions, and there's a wide-ranging scale from this. So it's a lot of uneven distribution, where certainly with classically you hear of folks here in the Western or Global North who are gaining a lot more recognition than sometimes, unfortunately, taking advantage of local partners. But on the flip side, sometimes you actually have circumstances where you are actually, as the Global North, providing the bulk of the work and yet still not being first or second author, for instance. So there is uneven distribution in the current existence. So what changes can we make? We are recommending finding local champions, promoting local leadership development, recognizing that the Global South is not homogeneous, and that unfortunately our Western grant structure is very rigid in terms of timelines that are very different than what our partners are expecting or wanting, actually. And that the missions of major funders, for instance, USAID, sometimes conflict with what we are trying to do in terms of decolonizing. I mean, USAID itself is, their message is, this is a gift from the American people. So, case in point. And we need systems in place to establish continuity of these projects rather than just one and done, as unfortunately a lot of these projects become. And that's where we've got to really engage these funders, but we don't have enough power individually as individual PIs. We need larger organizational support, such as overall SAEM, as an example. And then one critical thing is, we fortunately, because I know in this live environment, we're not able to get as many of our local partners to come and provide their versions of the stories. So we actually, fortunately, have Maria here from Mozambique, where she is the co-director for residents in Mozambique, and her superiors have tasked her with also establishing research, or leading in research for her hospital. The caveat, though, is her local partner, or sorry, her Western partners who come in, unfortunately, have their own agendas without performing needs assessments. Once they're done with their project, they take them go, and no research infrastructure has been left in teaching research methodology, et cetera. So what Maria really wants is actually the know-how and research methodology. How can they create their own programs to train their residents? And that, unfortunately, has not been done. They've been exploited, is the saddest way to say this. So,
Thanks so
that's
much.
it.
Awesome job, everyone. So you can all put your chairs back into the places they were. And also just a big thank you. That was really fast. That was more of an opening discussion, I think. So please also join our working group. Email me to be added to the working group, because this will obviously be revised and we'll continue to work on it. Thank you so much.